Welcome everyone from wherever you may be joining us this morning, this afternoon, this evening, or tonight for an incredibly special occasion and an honor for the Asia Pacific Leaders Malaria Alliance. My name is Sarthak Das and I'm the CEO of APLMA. To mark World Malaria Day, we very much felt it would be important to try to do three things. The first being acknowledging where we are as a world. We are continually learning the importance of local capacity, of what happens at subnational levels, what happens at provinces and counties and districts across the world. And that holds the key for us in so many ways in our fight against COVID. And in thinking about malaria too, we certainly know that the end game of malaria will require such a focus as well. And so with that in mind, we wanted to invite a dear friend, colleague, mentor, and teacher to have a dialogue today. So I'm delighted and honored to introduce Dr. Kamini Mendes. Dr. Mendes is a renowned malariologist, formerly of the Global Malaria Program of the World Health Organization. She's currently Professor Emeritus at the University of Colombo, Sri Lanka, also an independent expert and consultant in malaria and tropical medicine. She's a board member of the Asia Pacific Leaders Malaria Alliance. And perhaps most germane and relevant to today, she played a key role in launching Rollback Malaria at WHO in 1998 and in the certification of malaria being eliminated from Sri Lanka. And most importantly, has a tremendous wealth of knowledge to share on this topic of not only malaria, but building capacity at the district and subnational levels. And so with that, thank you, Kamini, Dr. Mendes, for joining us. It's delightful to see you.
Thank you, Sarthak. Delighted to be here. Thank you for inviting me.
Of course, thank you. So I'd like to start off by really probing on this question of the importance of local solutions and why does the subnational matter? Despite the availability of so many proven tools, whether it's in surveillance or vector control, IRS, why can't we have more of a one-size-fits-all approach?
So I think this is because Sarthak, malaria is a local and a focal disease, even though you might not see it that way when there is intense transmission. It blurs the picture. But as malaria comes down and you're moving towards elimination, you see this very clearly. There is a great deal of published evidence which shows that malaria transmission is focal and heterogeneous, meaning that even within a given area, some people and some places are more prone to malaria. So the focus in malaria control and elimination must also be at the local level, I think. And to interrupt transmission, it has to be someone who understands this. The action is at the district level. And in large countries, I think, where the districts are huge in extent, I would say even at a sub-district level.
So so deriving from this, what is it that we can extrapolate that needs to be done by countries?
So I think obviously strengthen the district level capacity and empower the districts. By this, I mean provide the districts with the commodities like medicines, the LLINs, the insecticides, diagnostics, and avoid stockouts and provide the necessary staff to deliver interventions. But this, I think everyone knows, and this is what we all know. There are aspects to the local level which are less appreciated. But we'll talk about it eventually, I think.
Yes, thank you. So thinking about this, and I reflect a lot on my, and I would love to share a little bit more about some of my experiences in this regard in hopes of probing your own experience. But when we unpack this idea of capacity, or to use the word with a lot of caution, empowerment. One of the things that I think we all know is whatever we're talking about, whether we're talking about the ability to forecast effectively for a particular commodity, or we're talking about taking data that you may have about the burden of disease and planning forward in terms of where you're going to devote resources. In the end, it is so much about program management. And I think a lot of emerging literature, even now, in terms of malaria, successful interventions in terms of malaria elimination, really points to a set of operational controls that are the end game. So whether it's about supply chain, whether it's about data, whether it's about evaluation. So it's about program management. And it's also about then at that unit of operation that you just described, whether it's district or even a large district, sub-district, it's about leadership, I think. So I would love to know a bit more about your reflections on that, and specifically within the context of malaria, about management and leadership.
Yeah, I think you're right. Leadership is something I think we don't talk about enough and appreciate enough, I think. At the district level, it has to be a person who obviously understands malaria transmission, but also one who will encourage the teams and at the same time set high expectations at the district level. Now, I think Sri Lanka had this. I mean, Sri Lanka is a country that, as we all know, eliminated malaria in 2012. And I think it was one of the critical factors that led to the success of elimination in Sri Lanka. Every district, every malaria endemic district in Sri Lanka had a regional malaria officer. And I think many countries have a district malaria officer or the equivalent. But the question is, how competent is that person and how motivated? The district person has to be committed, has to understand how malaria is transmitted and be accountable on what he does, he or she does. So I think this leadership aspect is something we need to nurture a little bit more. Over, Satak? I mean, you want me to?
Yeah, no, I think that's, and I'd like to discuss that a bit more. So one of the things that in many ways seems to be important, and you could use a variety of terms, but when you describe accountability, competence, motivation, one of the things that I think about is a phrase called supportive supervision. Or how do we create a model where there is accountability, but if we're introducing a new technology, a new tool, a new way, or it could be an old way, but things aren't getting done, we need people to certainly be accountable and be competent. And we also need them to feel free that they can speak up when they don't understand what's going on, and do so. Management is as much a science as it is an art. And one of the things in my own experience I've seen is that there can be tremendous power in building networks where you have providers, you have managers who have a task in front of them, but they're in a very remote place, in a rural place. and my own experience of this for many, many years was in the highlands of Papua New Guinea, where people were being asked to inculcate and practice things that were deployed a number of new technologies, whether it was dry blood spots for early infant diagnosis for HIV, or thinking about integrating different therapies. And in terms of supportive supervision, accountability, being able to manage a program effectively, creating networks of providers was critical across the spectrum, from quality assurance to data to M&E and to planning. And so can you say a little bit about that? How do you, what should that network look like? And what should they be doing? And what in practice was your experience of that in terms of malaria in Sri Lanka and what you've observed in other places?
So Satak, I think you're absolutely right in stressing this importance of not isolating the district level people. I think a strong link between the district level and the higher levels, obviously, of the program is essential. But also a constant dialogue and feedback between them is necessary. So in the case of Sri Lanka, for example, every month, all the regional malaria officers from the 24 districts would meet at the National Malaria Control Headquarters every month for 2 days and discuss, report on progress, talk about the challenges. And that was, again, a peer connection as well. So there were connections not only between the districts and the higher level at the national program level, but also among the districts. So I think these are extremely important. I mean, they can't work in isolation. It's so important to have them connected, and you know, they help each other with the districts, among the districts, and they sometimes have common problems, and you know, these districts are not walled off. I mean, people go in and out of districts. There's an enormous amount of travel in a country, and so that connection, I think, is important, not to isolate the districts. I mean, so we've talked about. So it's very important to focus on the district level. It's very important to empower them. And it's very important to have that link, to constantly establish a dialogue with them. And we'll come to monitoring and evaluation. But, you know, this is all a part of how to incentivize and encourage the work at the district level.
Yeah, yes. I mean, just for a moment to stay on that, I think another thing that before I move on to the next question, I think that it depends on the setting, but how important it is when that kind of supportive supervision is taking place, what a difference it makes during the times where those district managers are pulled together, or in the time where field visits happen, perhaps even more importantly so, to where they are. And maybe now this would happen virtually for some time, but that there's an active attempt, even within the limitations of resources, to at least ask, are you able to make it to the capital next weekend to see your child whom you've left? Or in what ways would it be better to do the refresher training so that people can marry that with other things that they personally have to attend to? I mean, the more remote you get, the more you realize how much, even if there are things you can't do, how much it means to people when you just ask, or you at least mention those things, and how often those considerations don't figure into the picture when programs are rolling out. And that becomes the glue that I think accelerates progress. And so often we don't, we're not able to. So yeah.
And it works. I mean, things improve on the ground when you do that kind of thing. These are the softer aspects of program management, which are so important.
So important. Yeah. So turning from the soft to something a bit more hard for a moment, I'd like to shift gears and ask you a bit about data. So what's interesting, one of the things among, here we are trying to all think of ways in which there are learnings about data through this experience of the pandemic and what it might hold for us and what's possible in other infectious diseases. And one thing certainly we are seeing, with all of its gaps, is that when there is such an intentional focus, it's remarkable how much data we're learning, how much we're learning about how much data we can generate or what the gaps are at the moment. And we see that in whether it's the Johns Hopkins map of the world or what different countries are able to do and not do. And as we know, in terms of malaria and thinking about our region and the end game, whether it's in places like Papua New Guinea or Eastern Indonesia or parts of India, it will rely on capacity building in regards to the analysis of locally generated data and the ability to then take action at that level. So what's your view on the importance of local data and what we can and can't do and what we should be doing differently?
So I think that's the other important thing. Local data is important to analyze and take action on at the local level. And data, as now everyone knows, is not meant to be just transmitted upwards to the national level and then to the regional level and the global level, which sometimes happens. The local data is what will tell you why there's malaria, where it is, and what needs to be done. And that analysis and understanding is critical, I think, for elimination. At this point, Satak, if I may, let me relate a little story about an event that took place during malaria elimination in Sri Lanka, because I think it might illustrate this point. As Sri Lanka was moving rapidly to elimination, and the incidence had already dropped to very low levels, in 2009, there was a small spike of cases. This was Plasmodium vivax at the national level. And this was due to a rise in the vivax malaria incidence in a district in the deep south of the country. The regional malaria officer in the district, sadly, she's no more now, she passed away due to an acute illness. She was a very good malariologist who investigated this focus and found that the cause was a growing outbreak of vivax malaria in the residence of a series of army camps located along a large river inside a national park. Now, to those of you who are listening and who may not know, this was towards the end of a civil war which raged in Sri Lanka for 30 years. So this was really the end of the war. That's why the reference to the army. She found that no amount of providing LLINs, IRS, providing good access to treatment was sufficient to halt this outbreak. It didn't make much of a difference. It was, she found, an unrelenting source of mosquitoes that were breeding, a source of mosquito breeding at the edges of this large river, which had pooled because there was a drought. So to cut a long story short, she got the collaboration of the army and the soldiers, and they larvicided 30 kilometers of that river. It was a Herculean task. And the outbreak came to an end very rapidly. By 2011, it was totally squashed. Now, I'm not saying that larviciding on this scale or on any scale is applicable everywhere, nor is it one of the mainstays of malaria control and elimination. But in this particular case, unless that breeding place was eliminated, and the outbreak would have continued. And I think had she not done that, it is very possible that Sri Lanka might still have malaria, because Satak vivax is quite difficult to eliminate. And this is exactly what happened in the Republic of Korea, because soldiers brought back malaria from the demilitarized zone, and they took it when they went home to other parts of the country. And that would have happened in Sri Lanka unless she squashed this epidemic. So I think this illustrates how every situation must be tackled based on the local realities of transmission. I think every district malaria person has to be familiar with the basics of malaria transmission. They have to be technically sound. I know that many countries have district malaria officers, but they may never have had a training on the basics of malaria transmission. And sometimes every 2 years or even less, they might be transferred to another post. Now, this kind of situation, I mean, what would be their incentive to eliminate malaria, and what would be their capacity? So I think we've got to think about things like this, you know, not just the technical advice, but these are people who are at the center of action. So I think I hope that sort of illustrated the point you're trying to make to all of us, that the local level is important.
Yes, absolutely. And it's a perfect illustration. And one of the things just to push on that a little bit in terms of, let's say, retraining or refreshers from a resource point of view, how much time, a minimum, do you think would be required if there was going to be a refresh training on the basics of malaria transmission? How much time would be required for that?
I think not much, Satak. I mean, we're not talking about long 1 week courses. No, I think people are smart. They can easily do an online training package, which must be even available. And I think this is something we really must start working on, an online package for people at the district level on the basics of transmission, malaria transmission, and giving examples. It's so easy. They can do it in their own time. So I don't think it's a long drawn out one, and I don't think it'll be costly. It'll be very cost effective, yeah, whatever you do, I think.
There's so many more questions I want to ask you, and I know we're getting close, and there people have also sent some questions in. So if it's okay, one really important question that I wanted to ask you was in regards to the use of tools and technology. And I think that all of us working in global health and global health delivery recognize that what a boon that we have in terms of the advances in science. And at the same time, it's a science of delivery. And there's no magic bullet, and there's no way to just make an assumption that new tools will solve the problem. And so any caveats in your view for the malaria community, or for that matter, those working in other infectious diseases in terms of, but in malaria specifically, tools and technologies towards elimination?
Okay, so tools and technology are so important. Without them, we won't be able to do this. That's quite obvious. But I would say that they have to be used with the understanding of how malaria is transmitted. I mean, for example, when malaria transmission is very high, then applying these tools in a blanket fashion is quite all right, and that's what's needed. But when transmission has begun to come down and you're approaching elimination, blanket coverage, just applying tools, whether it's LLINs or IRS or whatever, in a blanket fashion will not be relevant nor necessary. So from that point onwards, you have to apply the tools knowing where and how malaria is being transmitted. And technologies are meant to be adapted only as aids to malaria elimination. If you don't know where to use them and in what manner and in what context, they will have no effect. And you will see that amidst the sea of tools and technologies, you will see a persistence of transmission. This is why I think we often hear we often hear it being said that malaria elimination is difficult. Well, if you, with all the very, very powerful tools we have today, it won't be difficult if we know how to apply them and where and when. So I think that again comes back to, focal, local level action with a good understanding of malaria. And again, it comes down to the district level person.
So in terms of, thank you for that. And now in terms of thinking about both, well, now and moving forward, based on the assumption that COVID will be with us for some time, and likely there may be another pandemic at some point in the not too distant future. What guidance would you have on the future of a vertical program such as malaria in terms of this time that we are now living in?
Sadak, I don't think today that we'll find a truly vertical malaria control program anywhere in any country. I think most, if not all countries, there is a national malaria control program which works very well through the provincial health system. In other words, it's partly integrated, partly not even horizontal, it's diagonal. So let's talk about that. So there is, but I believe that even after achieving elimination, a dedicated malaria control program is a must. I mean, again, you brought up this issue of the COVID pandemic, and this is the elephant in the room. I believe if in Sri Lanka today, which is in the phase of preventing reintroduction after elimination, I think if there was no malaria control program, which is running perfectly well today, I believe when the pandemic hit, districts and everyone, the health system was totally distracted by COVID. I mean, distracted is probably the wrong word. I mean, they were fully engaged in battling this epidemic. I think malaria might have come back if there was no one to keep an eye on malaria. What I'm trying to say is that I think it's important that even after elimination, but certainly before elimination, that there is at least a very strong, robust central malaria control program, which keeps an eye, which provides the guidance, sets the norms and the standards, and does the monitoring and evaluation. Without that, no matter what people might say about not being vertical, I mean, this is the only bit of being vertical, which I think we have to preserve. We need a disease-specific program. Otherwise, it's not doable. I don't believe it's doable.
So then how can we balance the need to complete our task in malaria while strengthening the system? Because this will be certainly as a Leaders Alliance and one engaged in elevating technical advocacy, keeping malaria on the agenda, but really making the case that we're strengthening the system.
Yeah. I don't think.
Is there a contradiction?
I don't think there is a contradiction here. I think if we strengthen, I firmly believe if we strengthen malaria services to the point of completing our task, we strengthen the health system. Malaria is a disease that puts the health system to a real test. It's an acute disease for which people seek treatment very early. They come rushing to the health centers. It needs very effective diagnostic services and treatment facilities. And when there's a lot of malaria, like in some countries, it constitutes a large proportion of the outpatients department services. So what better way to strengthen the curative sector than by responding to malaria? And similarly, on the preventive side, we don't have time to elaborate, but the same thing happens on the preventive side. So I think wherever there is a well-functioning system, it serves as an example to other programs within the health system and other arms of the system. Besides, I think most countries, malaria staff get transferred to other posts in other parts of the system, and they carry with them the experience of a well-functioning malaria program, and that will in itself strengthen the system. So I firmly believe that responding to malaria is also strengthening the health system. There is no question about it.
So one last question before we close for you. what would be your advice to donor agencies and policymakers?
Who am I? Who am I to advise?
Hey, well.
But if you ask me, then I would say help strengthen the country capacity by letting the country do the work with its own staff. I mean, all these countries in the region, in China, Sri Lanka, even Timor-Leste, Bhutan, all these countries eliminated malaria through their own efforts without much external support, except, I mean, the Global Fund played an enormous role. The WHO provided technical assistance. The partnership secretariats in the region provided a lot of support. But they have to own this and do it on their own. So I would say strengthen the national capacity and keep the focus on the district as much as on the center, and invest in monitoring and evaluation. And I think this is what the Global Fund did very well. I always think that one of the successes of this elimination drive is, quite apart from many other things like, you know, the partnership secretariats like APLMA, World Health Organization guidance, was the monitoring and evaluation element that the Global Fund funds were tied to. That was, I think, very important.
Well, I know we had only allotted this as a brief discussion, and I hope it's just a teaser. We did have so many questions. I'm wondering, could we request to keep you for maybe 5 minutes just to answer a couple of questions? I think not to disappoint. Is that okay?
Of course, it's a pleasure.
Okay, great. So one question that we've had here is, for countries that are badly affected, and I think you already answered this in some ways, but it's one that's come up again and again in the questions here. The response to COVID has pulled attention and resources away from disease elimination, including malaria, and the challenge for the programs is to get back on track. So anything else that you can say to help countries adapt and adjust to the disruption?
This is tough. I mean, one thing, I mean, obviously, you know, COVID, we've had COVID now for over a year. And I think even the health policymakers realize that there are other diseases. They can't just completely go away from the realities of handling other diseases. So I think all the countries, they're beginning to see this. I think it's important for the people in malaria to get this message across. When people at the high level listen, Satak, they listen when you tell them that, you know, the consequences of ignoring malaria would be this, they will. I mean, countries, they have resources. It's sometimes a knee-jerk reaction, you know, in many countries. Whatever is the biggest problem, everyone focuses on that. Sometimes, it's, as I said, it's a knee-jerk reaction. So I think we've got to advocate and be persistent and say, look, we've got to, you know, if the high levels say, you know, we are going to take all the malaria staff away from this. You've got, I know it's easier said than done, but I know Sri Lanka is doing it. I know several countries are doing it. You have to say, but you know, this is what we have to do. Otherwise, the consequences would be such and such. I mean, many countries in the region are on to elimination. I mean, they are clearly on the path to elimination. Almost all countries. It will be such a sad thing to see them. You know, turning back, and if malaria comes back. And, you know, as Peter Sands the other day said at a meeting, malaria is a disease that, you know, you either eliminate it or you go back, because it's not going to, you can't do it halfway and expect it to remain there. It doesn't, there's no treading water here.
Right.
That's something we really must appreciate. You've got to go to the finish line. Otherwise, you're back to, you know, it comes back. Well
said. Thank you. Here's another question in a very on a different theme, more specific theme to subnational level. So, how can, any view on how we can strengthen entomology and vector control at the subnational level by strengthening the link with Aedes, especially where we're talking about breaking down silos, let's say, between dengue and malaria. Any guidance in regards to this?
Yeah, I think entomology, I mean, thanks to whoever asked this question. I think entomology, strengthening entomology is important. It's suffered too long, suffered neglect too long. I think entomologists must be good malariologists as well. I mean, this is something we don't appreciate enough. Entomology is not just insects. Entomology is knowing about transmission and malaria. As I told you, that district malaria officer I talked about, and there are many such, I just gave you one example, who did that last bit of Vivax elimination in Sri Lanka was an entomologist, but she was above all a malariologist. So yeah, I think it's a challenge. We have dengue, and dengue sometimes is even higher in incidence than malaria, and you've got to share stuff. So I think here it's a bit of integration, Satak. We've got to we've got to look at both. I mean, when you go to do an entomological surveillance program, you can't just look at anophelines, which transmit malaria. There are Aedes mosquitoes in that breeding place. You can't just not note them down. You've got, we've got to adapt now. And, I used to say sometimes, if there was an elephant in that well, you wouldn't notice it. You'll just tick off the anopheline and come back. That won't do. So we've got to learn the painful task of integrating. It's not easy, but it's reality. Not fully integrating, but sharing data between these, at least the closely related diseases.
Sure. Oh, wonderful. Thank you. Well, I have learned so much, and I hope that we get to do this again. My thanks to all of you who joined for this discussion in whichever time zones you're in. It was really, really just a pleasure to be with all of you and to be with you. Thank you so much, Dr. Mendes, and I hope that we can continue to have your voice in this community so we can finish the job that we've started. Thank you.
Thank you very much for having me.
Thank you.
Thank you to all who joined.
Bye-bye. Bye-bye.
Bye-bye.